Welcome to our MCPAP for Moms webinar. So what we're going to do is, I'm Nancy Bai, I'm a medical director for MCPAP for Moms, and we're pleased today to be having our topic be bipolar disorder with a focus on screening, assessment, and management during the perinatal time period. So just a few housekeeping things. The session will be recorded and available on the MCPAP website at www.mcpapformoms.org. A copy of the PowerPoint slides will also be available on our website on the Toolkit and Resources page under PowerPoint presentations. Our presenter, Dr. Marsh, will also stop for questions at several points during the presentation, and there will be time for questions at the end. And if you do have a question or comment, please type it into the question box during the presentation, and we will read aloud your question or unmute your line to enable you to ask your question. You're also going to receive a very brief survey following the presentation. We really appreciate your feedback, and this will help us improve future presentations. So I'm pleased today to introduce Dr. Marsh. So Wendy Marsh is an associate professor of psychiatry at UMass Medical School. She received her MD from Wayne State School of Medicine and did her psychiatry internship in Stanford. She remained at Stanford for specialized fellowship training in women's mental health and mood disorders. She came to UMass after her fellowship, and she had a K Award and earned her Master's of Science degree and continued her clinical and research work. She's a founding member of the Women's Mental Health Clinic, the director of the Bipolar Disorder and Depression Specialty Clinics at UMass. She teaches residents, publishes, and presents nationally on reproductive aspects of mental health and mood. So, Wendy, please go ahead, and we can stop for questions throughout. Just please put those in the chat box as you have them. Thank you.
Hi, this is Wendy Marsh. It's a delight to be here. I'm so glad to be speaking to you. As you heard from Dr. Bai, it's bipolar and reproductive phases, in this case, pregnancies, a particular interest of mine. So it's so important. So I'm glad to be here to tell you about bipolar disorder through pregnancy. Kind of focusing on screening and management here. Great. So 3 sections. We're going to start off with the diagnosis to do a review, and then talk a little about bipolar in the field, epidemiology, and then moving on to screening, and then management of how do we treat and care for a woman with bipolar disorder. So just as I talk about bipolar disorder, it is the same thing as manic depression. It tends to be an older description, calling it manic depression, but the idea is that there are 2 poles of the mood, one being the mania and one being the depression. This is a bit simplistic because people can have some overlap of symptoms, but in general, we have the depressions and the mood elevations. The depression here, these are identical criteria for what I'm going to call unipolar depression, to clarify that from bipolar disorder. As someone who works a lot with mood disorders, this helps keep them separate. So unipolar and bipolar depression have the exact same criteria. So the individual needs to be depressed, sad, blue, down, or what we call anhedonic, without joy, this feeling flat, blah, often feeling like they're not connecting with their loved ones. If they won the lottery, it wouldn't make a difference. They may not be sad, but just that flat feeling. That plus the 5 symptoms from the symptom list, that's the same as unipolar depression, has to be for at least 2 weeks. And with any disorder, it has to cause dysfunction. So not making it to work, losing friends, school, it's hospitalized, causing problems. Mood elevation, it's important to note closely here. Elevated, expansive, or irritable mood, plus increased activity or energy. So we need this combination. And what I want to emphasize is not necessarily a grandiose, I can do everything, I'm invincible experience. It often is, but it can be a very unpleasant experience. They can be irritable, red light too long. They're shouting at and in mood elevation, they might be shouting at someone on the 800 line or across the counter at the grocery store. So it can be an unpleasant experience. And then we have 3 or 4 symptoms. I'm going to go through mania, mood elevation, a little bit more detail here. It has to be at least 4 days. Often it lasts much longer. And abnormal. Mood elevation come in severities. At the worst end, a full mania is dysfunctional, but the milder manias, hypomania, just below mania, might just be abnormal. But they both have the same number of symptoms. It's just the difficulty that it causes. So we have the, this is a criteria you may have remembered back in training, but the sort of quick and easy way. We have that irritable, elevated, expansive mood, increased energy, plus the dig fast stability. Indiscretion or irresponsibility, pretty typical, not uncommon. You hear about people spending inordinate amounts of money, or money they just don't. 100 miles an hour, grandiose. This is the I can do anything kind of experience. I've had people feel like the consequences just won't happen to me or don't apply. Flight of ideas. Their brain is rolling at 1 million miles a minute. They can't keep their thoughts straight because they're moving so fast. Activity. So they're doing different projects. They've started way more plans, activities, goals than is reasonable. And because they're distractible, they often don't finish them. Sleep. This is one of the most unique features in a mood elevation, increased need for sleep. So 3 hours or less and feel well rested and that they're full. I've had people say they don't sleep for days. They're going at 3 in the morning, taking a toothbrush to the grout or repainting the kitchen. And then the talkativeness. You'll see this on exam. They not quiet, or they just feel such a need to communicate and express themselves. It's hard to get a word. So that's a constellation of symptoms for a mood elevation, as a reminder. Bipolar is a lifelong illness. So once diagnosed, true diagnosis of bipolar, not always, but there's often. But once the real diagnosis of bipolar is made, there's a lifelong ability depression or mood elevation. Most people spend the majority of their time euthymic in a healthy mood, but there's always that vulnerability to a mood elevation or depression. Bipolar is 1% of the population has the more severe bipolar 1 with the full manias, but other reports say up to 3 to 5% of the population is bipolar spectrum. In this case, I think this was 2.6%. Bipolar disorder is a leading cause of disability. If your moods are all over the place, it's hard to function at work. It's hard to keep focused and concentrating, and it causes problems. And the onset, typically in the late teens to early 20s, and this is starting your reproductive, often reproductive years. So that is treat pregnant women. There's no question, bipolar is difficult to diagnose for those of us in the field. There's a high rate of misdiagnosis, up to 7 out of 10 patients on the first evaluation. And 1 in 3 can wait 10 years before getting the correct diagnosis. So part of where this talk is going is, why might this be the case? And so if you think about it, you have the 2 poles. So to be diagnosed, you need to have experienced both, unless you've had a full mania. But typically, one has experienced both sides of the mood to be diagnosed. So what happens is the bipolar is most often misdiagnosed as depression. Even though, and this is particularly true in women. So an equal number of men and women develop bipolar disorder. It's not solely a woman's diagnosis or solely a man's. We do get pretty equivalent rates of diagnosis. A little bit more background, it affects all races, ethnic groups, social classes around the world. This is not unique to America. But what happens is women with bipolar disorder do have more depressive episodes than men. And when someone comes to the clinician with complaints about their mood, they typically do so when they're in a depression or about depressions. Hypomania, the milder mood elevation, may not cause problems. It may not be an issue, or they may have enjoyed it. So you don't go to the doctor and say, hey, I had a really great time last month. No, you go saying I'm depressed and I'm, suffering and having trouble. So it's not always easy to diagnose a mood elevation. The manias tend to be more severe. Once hospitalized for mood elevation, that's a mania, and that's often clearer, but not always. So a number of reasons why it's important to screen for bipolar. And refocusing now more on our reproductive women in pregnancy. One is pregnancy does not protect a woman from mood episodes. Hopefully you're all aware of this for depression. It is true for bipolar as well. Just because she's pregnant doesn't mean her hormones or, having a new life inside of her prevents mood episodes. These women continue to be at risk. And stressors can bring out episodes, mood episodes, and being pregnant can be a stressor. The mood episodes do confer risk in pregnancy. I'm going to highlight mood elevation here because it's a little less recognized, I guess. And it is less well studied versus the risks of depression in pregnancy. But we do know in mood elevations, women take on high-risk behaviors such as substance use. There's an increased risk of substance use, and then poor self-care. And those can have consequences in the course of the pregnancy. And we find with mood elevation, it can be associated with low birth weight, preterm, and small for gestational age. And then just to review, because we do have the depressed pole and bipolar disorder, it has risks. It's the same symptoms as unipolar depression. So risks of unipolar or bipolar depression for the mom and through the pregnancy can be the preeclampsia, again, poor nutrition and self-care, visiting the OB lab, and increased risk of substance or nicotine use if they're depressed, they're mood elevated, they're distressed, and they're looking for ways to mitigate that. With depression, there's a risk of suicide. Depression, risk for preterm labor, and then being pregnant, and particularly in that last trimester depressed, increases the risk of a postpartum depression. The fetus or infant does have experienced consequences from the depression as well, with less growth, increased risk of prematurity, after birth, decreased sensitivity and attachment, potential behavioral problems. And in the postpartum depression, it can be associated with cognitive delays, to name some of postpartum. Bipolar disorder increases risk of postpartum psychosis. So I'm going to take a moment to use this. And this is a bizarre, odd, irrational experience. And this is more than Sarah. And when hearing their name called is not a big, not of concern. But if their voices are talking or telling the patient to do something, what we call command hallucinations, that's a psychotic experience, auditory hallucination. Paranoia. This is not just a suspiciousness, oh, I think they're talking about me. That group is from the, they're talking about me and they're going to call me into the, the greater governmental surveillance system. That's a paranoia. I had one patient tell me there were video cameras in the light bulbs. Yeah. So auditory hallucinations, paranoia, delusions that people are convinced are true, when they're given information or evidence to the contrary. So, or it could be just, as we know, impossible, reading minds, future, removing thoughts. They can come in a host of ways. Ideas of reference, you know, the TV's talking to me, that's also. Okay, so with mood episodes, high risk in the postpartum time for people with bipolar disorder. Luckily, they're rare. Maybe 1 in 2 women out of 1,000. Of those who experience it, 70% are bipolar or more. They come on, you know, the postpartum theory can have a few things, but the psychosis comes on within the first weeks, day to weeks postpartum. So we have the mood symptoms, typically depressed, but they can be mood elevated. And again, there are occasions when people can be feeling miserable, their self-esteem's down, a lot of guilt, and yet they're energized, irritable, revved up, being what I'm describing as a mixed episode. But they're having clear mood symptoms, they're having the bizarre thinking, and sometimes they can be disoriented. So in case of delirium, there are certainly medical concerns that can arise at postpartum time. This is a psychiatric emergency. This woman is suffering, and there's risk for too. And the worst concern is the infanticide. But it's serious, and we want you have the woman escorted to mental health or psychiatric services for evaluation. Okay, even though bipolar and unipolar depression have the exact same criteria, they have entirely different treatments. I cannot emphasize this enough. I'm going to talk about screening coming up, but this is one of the main key reasons to screen a woman who's depressed. Unipolar antidepressants are not going to work for bipolar disorder. There's no evidence for them. We do not treat bipolar depression with the unipolar antidepressants. Things are things like SSRIs, Prozac, Zoloft, SNRIs, Effexor, Duloxetine, or Cymbalta. Those are not appropriate for treating bipolar depression. Thankfully, they usually do a bipolar mood course, you know, especially men are calling us or getting psych for their psych evaluation. That's not because it can happen. I've certainly seen it. And so I'm going to talk to you about how to screen, and this is one of the key reasons to screen, that these SSRI, polar antidepressants, are not appropriate treatment for bipolar depression. That being said, when we do look at bipolar disorder, the treatment with the best evidence by far are medications. And I'm going to talk to you about those. Go along here. Polar says, yeah, no, I'm going to do with spa therapy. Wonderful. That might help relax them, but it doesn't treat a depression or a mania. And what I'm trying to get at is they need to be seeing a prescriber who can their mood. Okay. And so this leads us into the screening, and I mentioned some of the importance, but that theme will be for a section. Okay, screening for depression, and this is for the current depression. She walks this. This came up in one of my. Do we need to screen everybody? That's what screening means. If you just giving it to people who you think already, that's not a screening. So, screens for current depression, and again, because the same criteria for unipolar are the same for bipolar, these screens screen for both types of depression. The Edinburgh Postnatal Depression Scale, EPDS, is validated in pregnancy as well. 10 items, I'm actually going to, comes up here, multiple languages. One of the reasons it's wonderful in this patient population is it's more focused on the cognitive symptoms. So the guilt, the decreased self-esteem, the, feeling sad, less enjoyment. that experience versus trouble sleeping, well, she's pregnant, change in appetite, she's pregnant, change in energy level, symptoms of depression that overlap with pregnancy. So it's not, yes, really works more on the cognitive or thoughts, experiences in our head. The health questionnaire is just fine. This PHQ is often used in primary care. No need to switch over to EPDS if your system is already using it. The main thing is screening for this depression. And our diagnostic, our DSM, Diagnostic and Statistical Manual, are and because the diagnosis for depression, like I mentioned, includes energy, appetite, it also includes these physical symptoms. Okay, here's an example of the EPDS. We have 10 questions here, and they scored from 0 to 3. This last question, it's a little hard to read. 1 second. I don't leave prior to screening, prior to scoring. That's because someone to say answer yes, often I'm goodness, what do I do? So please take a moment to score, or at the very least, check questions using this as a screening that the patient fills out prior to in the appointment room. You don't want that risk, and we want to. Is straightforward, easy round number, possibly depressed, and then 13 are bad. That over is probably depressed, and this has been validated. Okay. And for depression, you're like, okay, great, but now I don't know if it's unipolar or bipolar. Just to give you a little background, this is with the EPDS. Population women who are pregnant or postpartum. Of the women who screened positive with the EPDS for depression, 23, almost a quarter, 23%, almost a quarter of them actually have bipolar disorder. So it's not like it's, a small fraction, rarely found, it's not happening. This bipolar is happening all the time. We're probably missing it more than we know. And this is why it's so important to do the next part of the screening. Again, just to reemphasize, that's almost one out of every 4 patients who has a positive score on the EPDS has bipolar disorder. This is truly a bipolar depression. And thus, it means they need a different treatment than an SSRI or a therapy or a standard first line for a unipolar depression. Okay, here we have the mood disorder questionnaire. This is for, and although it's called mood, it really screens for a mood elevation, so the second pole of bipolar disorder. But I do want to emphasize this mood disorder questionnaire is not just about the last 7 days. This is a history of ever. So it's asking the patient to think back a little further, but again, bipolar is a lifelong diagnosis. If they've ever had a mood elevation, and they're coming to you with a depression. But pretty much if they've ever had for the case of this, if they've ever had a mood elevation, they're bipolar. So section 1 here is a bunch of symptoms. You'll see they reflect quite closely the ones I ran through with you for the DSM. But if you have these symptoms spattered randomly, sporadically, not as big a deal. It's question 2 if you've had them all at the same time, simultaneous. And then question 3 is if it caused problems. Not as big a deal if it doesn't cause problems. So again, emphasizing MDQ screens for a history of ever. Unlike the EPDS and PHQ-9, which are in the last few weeks, MDQ is ever a history of mood elevation. So we need 7 of the symptom questions, yes to simultaneous and yes to moderate or severe. Pretty logical. So that's for the patient to fill out. Like with depression, I didn't do a screening by practitioner, but are you feeling sad, blue, depressed most days, most of the day? Would be a screening question for depression. We do have screening questions for the practitioner to use with the patient. This one is from our website. But the key is to get the high, hyper-excited, that elevated, expansive mood experience. And if you had a time you felt high, hyper-excited, and had increased energy for days or more. If you get starting to get a yes on that, ask if they slept less. And there's next to nothing else that'll lead you to need less sleep. And if you start to get a yes on that, then you really have a high concern, low threshold for considering bipolar as an appropriate diagnosis. So if you're sitting there with a patient, can't find the MDQ, ran out of them, haven't been doing it, have you had a time you felt high, hyper-excited, and had increased energy for days or longer, and then needed less sleep, 3 hours or less during that time? Okay, so we have a 1-2 punch here. You use the EPDS and then the MDQ. And that way you screen for both the depression and the mood elevation. Again, re-emphasizing the treatment for bipolar is entirely different from that from unipolar depression. So we want to make sure we're getting the diagnosis right. So we'll be using evidence-based treatment and decreasing the risk of unintentionally switching the mood to a mood elevation by giving a typical unipolar antidepressant. Okay, so that's if the patient, it kind of went through the screening if the patient presents depressed. Some moods are contagious, and this woman just captured a mood elevation. If the patient comes in on exam in the appointment and is mood elevated, you're likely to see these kind of symptoms, these kind of, we call a mental status exam, but she's going to be talking a mile a minute. She has so much to say. She just is going on, and you have a hard time getting your standard exam questions in. She's highly distractible. She might talk about one thing and then talk about something you left on the counter or the new poster up on the wall. Increased energy. So she's not just sitting there like usual, but she might be fidgeting or shifting or pacing. And then if you hear the content of what she's talking about, this is where we have increased goal-directed activities. I just booked us tickets for Disney tomorrow, or, I'm going to write 3 essays and finish my PhD by the end of the semester. And then especially concerning if she's talking about doing risky things, behaviors, but that may come up in the content as well. And then if you take a look at her, if you've known her over time, the appearance can change. Brighter colors, using hot pink where she's usually a blue colored, or increased makeup or revealing clothing. Suddenly she's shaved her head, or So these are things to look out for on exam. So we talked about depression. We talked about a mood elevation. The patient also may present euthymic. She's in a good, healthy place. Ideally, this is where we want them to be. But that doesn't mean she doesn't need treatment necessarily. And it doesn't mean she doesn't have the diagnosis. Okay. Again, once bipolar, it is a lifelong diagnosis. So she comes in saying, I used to be bipolar, but I'm doing fine now, and blah, blah, blah. I'm going to talk about what to do if you have someone with bipolar. It sounds like it used to happen and doesn't happen anymore, or that's not an issue. You really want to be on the alert that if she used to have bipolar disorder, probably still has it unless the original diagnosis was wrong. So things that I just had a patient, bipolar disorder comes with a number of comorbidities. Approximately half of women or anyone with bipolar disorder has an anxiety diagnosis as well. So these are generalized anxiety, post-traumatic stress, obsessive compulsive, and this needs to be taken into consideration depending on the severity and what treatment mode to use. They're at higher risk of substance misuse compared to the general population, and substance misuse can complicate the diagnosis. If they're mood elevated and they're doing risky things, and one of those risky things tends to be a stimulating substance, and that might be keeping them up overnight. It can get confusing, but they can definitely co-occur. They can happen at the same time. It doesn't have to be one or the other. And then those are psych, and then in the physical realm, the higher rates of metabolic syndrome. This often happens with some of the treatments, but it's been found in women with bipolar disorder prior to treatment as well. So it's something to follow during the pregnancy, high blood sugar, increased weight, such like that. Okay. I'm going to move on to management of bipolar disorder. The first thing to do, is to give MCPAP for moms a call or the patient's psychiatrist. That's what we're here for. And this is something that definitely needs to be or is by far best treated with someone who specializes in psychiatry or psych prescribing. If you are a psychiatrist, give us a call. We can help you through it too. But anybody in primary care, obstetrics, please give us a call. This is not easy for anyone, and you want the best expert you can get to help you out, mostly to help the patient out. Okay. So our main goal is to have the patient doing well, that euthymic mood state. And this may very well mean prophylactically using medication for bipolar disorder. This is the standard of care outside of pregnancy. So just because she comes in doing well, she can stop her meds, well, give us a call or talk with a Prescriber, or she's not on meds and she's doing well, again, give us a call. I think it's clear if she's in a mood episode that you want to treat, and the best evidence for treatment is the medication. Having a birth plan or a plan in place, whether it's medication management or support or managing that's part of the limiting or reducing stress, because any stressful event, even good ones, can increase the risk of a mood episode. Monitoring closely. The rate of onset of a mood episode can vary from patient to patient and actually mood episode to mood episode. And so it's important to keep track of how she's doing. In the context of, again, the stability, reducing stress, management, and talking that through with the patient in pregnancy can be a great way to be proactive in planning that. You've heard me repeat that the main treatment is medication, but there are things the patient can do or one can do outside of medication. And what we found is that regular daily schedule, the circadian rhythm, the better that's kept regular and even, the more regular and even the mood is. So getting adequate sleep, which is not always easy in pregnancy and postpartum with a newborn. And then even the weekends, or even, if she normally goes to work and now she's postpartum and doesn't have a work schedule, getting up at the same time every day. I can't tell you how important that is to help keep mood stable. That's been studied. That's been the key factor. But other things in a regular day schedule is getting up at the same time, getting out of the house, eating meals, socializing. As much as that can be kept routine, the better. Limiting stress. This is not easy when you're anticipating a newborn in the house or things happen in pregnancy, but as much as possible anticipating and planning. And then supporting the maternal-infant bond. This can help. They look more about the effects of the mother on the child. Some have actually looked at the effects of being a mother and having a child in the home, but supporting that for both involved. Okay. So now let me move into the medication, our best treatment for bipolar disorder. There are three main medication mechanisms. So one is the salt. This is lithium. There's no other medication out there that works like lithium. It's unique. It's a salt. And then the anti-seizure or anti-epileptic drugs, AEDs. The examples here we see a lot of lamotrigine, and I'll tell you why. for bipolar disorder. And then there's good reason to be aware of valproic acid, valproate, Depakote, Depakine, that anti-seizure medication as well, particularly for pregnancy. But those are two of the more common that we see for bipolar disorder. And then the third are antipsychotics. And this I find an unfortunate name for these meds, but that's what they are. It's kind of like calling SSRIs antidepressants when they work for anxiety. They have excellent evidence for anxiety. We treat for anxiety even though the person may not be depressed. So these antipsychotics work for bipolar disorder, even if the patient has never been psychotic and never will be psychotic. So they help keep mood stable. And within the antipsychotics, we have essentially two categories. The typical or first generation, these are the older ones. Haldols, most often known, perfenazine, can be seen sometimes in pregnancy as well. These older, those are the there's a bunch of older meds we see very rarely. And then the atypical or second generation, and these are a growing number of medications, but two that we see quite often with bipolar are quetiapine, also called Seroquel, and aripiprazole, also called Abilify. And I apologize if I didn't mention lamotrigine, the trade name is Lamictal. So there's salt, anti-seizures, and antipsychotics for treatment of bipolar. Going into each one of those, again, I mentioned lithium is unique as a salt. It is considered the gold standard. It's been in use for bipolar since 1950, which is when we first had treatments for bipolar, the first being lithium. Yeah, I can go more history of that some other time. It's from Stardust, if anything, and some people are just uniquely, I want to say, they just respond to lithium better than any of the other meds. And so it may come up that although we have, many other options out there now, that this woman just responds to lithium, and that's the medication that's clearly best for her bipolar disorder. It treats and prevents mood elevations, even ones with psychosis. It treats and prevents depression. The wonderful thing about lithium is that we have good evidence that it reduces suicidality. Okay, that being said, it comes with a number of side effects, so it's not always easy to tolerate. Some of the ones that are most tightly connected with it, that are, I don't want to say necessarily unique, but a signature of lithium can be the tremor. And this is related to the plasma levels, which we do need to follow. A larger tremor often indicates higher plasma levels within an individual. And it has a host of sometimes strange ones like acne, but it increased appetite, sedation, sometimes feeling a little not as on the ball or quick. So it can be not the easiest to tolerate for the patient. However, if it's what keeps their mood stable, we've got to take a look at the risks and benefits and on balance, do what we need to help the woman do well. So we do follow plasma levels and call your psych expert for those. But we follow them both for the efficacy. We have a clear range, 0.4 to 1.2, and then again, the higher levels are associated with more adverse effects. Lithium does come with risks in pregnancy. It's not our first choice, but sometimes it's the best choice, I guess. And these can be difficult to separate from concerns about mood episodes. And like with unipolar depression, a patient could be on a treatment and still experiencing mood symptoms. But that being given, lithium has been associated with preterm labor, polyhydramnios, polyuria, polydipsia, or diabetes insipidus, and then lithium toxicity. There's a lot of fluid shifts in pregnancy, and so that psych provider who's ever prescribing is going to be following their lithium level closely if all is going according to the plan. It can have some negative outcomes or concerns for the fetus and newborn. It can be large for gestational age. The cardiac defects, Epstein's anomaly, is actually much less common than originally thought. I believe it's about 1 in 2,000, so quite rare, but a little less rare than not using lithium. Neural tube defects have a smaller but increased risk compared to the population. And then especially those uses in the last few hours or days can lead to neonatal adaptation, it's a hypotonia or floppy baby in the newborn. And then there's some questions, some concerns about long-term developmental issues. So coordinating and managing a patient who's taking lithium, a pregnant woman who's taking lithium during pregnancy, we do recommend high-risk OB. It's always possible depending on where the patient is. Doing that fetal echocardiogram at 16 to 18 weeks because the slight but increased risk of Epstein anomaly. And then monitoring those lithium levels closely, thyroid, lithium affects thyroid changes in pregnancy, and then renal function being a salt, it gets excreted to the kidneys. Potential consideration for everybody to watch, including OB providers, that if the woman starts taking medications for headaches or pains, such as NSAIDs, can raise lithium levels. Diuretics increase lithium levels, as do some other medications. And then lithium levels are decreased by caffeine and theophylline. So as a salt, it does vary based on hydration level. If someone's out in the sun sweating, their lithium levels will go up versus well hydrated, the lithium levels would be lower. So it does vary almost day to day. The lithium levels not horribly usually, but there's some variability, and we do want to watch those, particularly as the pregnancy progresses. So that's lithium. Some people are just uniquely responsive to it. It may be necessary in pregnancy. It's not our first choice, but we do want the woman's mood to be as close to or as euthymic as we can keep it. Antipsychotics and bipolar disorder. As our second group, again, although they're called antipsychotics, they work for mood that has never had a whiff of psychosis, nor will it ever. Our first generations, like Haldol, they all treat mania, and they can help prevent mania. However, they don't have very good evidence for treating depression. So someone may be on 2 medications, one for treatment and prevention of depression plus first generation typical antipsychotic. Side effects for the older antipsychotics are these muscle movements or extrapyramidal symptoms. And the EPS is a very broad-ranging term because you can have anything from shakiness to the oral buccal chewing or abnormal movements. Any extra can be often oral buccal, but facial, and sometimes even some more painful muscle contractions that can be slow over hours and very uncomfortable. Luckily, they're not all that common, and it tends to be with older people or those who've taken the meds over a longer time. That being said, anyone can experience these, so it's not that our young reproductive age women are immune either. Okay, second generation or atypicals. This is the ceracolchicine, Abilify aripiprazole. We're seeing now lorazepam, Latuda is brand new. I'm trying to think what else there was. Olanzapine, Zyprexa is in this group. Again, these all treat mania. So all the antipsychotics very clearly treat mania. They're excellent for it. But a number of these, they're also treating bipolar depression. So I do a little dance. We can treat both sides of the mood and with one medication. They do come with side effects. The main one for the group is the worsening the metabolic profile. So in pregnancy, watching for increased risk potentially of gestational diabetes or excessive maternal weight gain. These are side effects outside of pregnancy, but they can contribute to concerns that one already has during the pregnancy. Okay. How do these are affecting the fetus or the newborn? The first generation antipsychotics, I mentioned the EPS as a side effect. This also can be of concern in the newborn. Usually it's pretty transient, and it tends to be a smaller risk. I mentioned then the second generation, the gestational diabetes and obesity. Teratogenicity between these two, thankfully, is not looking increased above the general population. The first generation have been used for decades clinically and used in pregnancy, and we're not getting reports of that being of concern. There's a registry for the new atypicals, and there's some new data out, but in general, it's not looking like it's increased in the general population or for the second generation as well. So that much is reassuring. For the first generation, we really have limited long-term data. What we do have reassuring as far as cognitive, behavioral, ongoing concerns after exposure in utero. The second generation, we have reassuring data at 12 months, they're hitting their milestones at time, and then we're starting to get some data for specific ones for a little longer than that, and so far, so good. So that's a sort of current state of our what we know about these medications in pregnancy. Okay. It also emphasizes that there's a lot we don't know, and there's it's important also to discuss with the patient that it is tolerating the unknown of treatment and mood and pregnancy. Our anti-epileptic or anti-seizure meds for bipolar disorder, unlike lithium and antipsychotics, not all of these work in bipolar disorder. So lamotrigine or Lamictal. This is a little bit more complicated picture than the first two, that's why I kept it to last. But lamotrigine, it treats depression, bipolar depression. That's all it treats. It does not treat mania. You don't use this medication if someone's running around manic or high risk of mania. In the bigger picture, we've had a hard time treating bipolar depression, so this has been a wonderful medication to add to the regime because it's really well tolerated. People aren't gaining weight or blood sugars. You don't get headaches or sleepiness, sedation. It's just been fantastic. But it only treats bipolar depression. Depakote, I'm not sure I should have crossed that out in some sense, but I did because this is not a medication we want to use in pregnancy. But in the bigger picture, treating bipolar disorder, or when one comes in on this medication, getting a sense of what may be being treated here, it does treat mania. There's some evidence that it treats depression. It's not the best bipolar antidepressant, but it may very well be helpful. It does have a lot of side effects like increased appetite, sedation. It can have tremor. It's not the easiest medication to take. Like lithium, we do follow plasma levels. All that being said, ideally when the woman comes to you, if you're an OB provider, or comes with it to the appointment saying she's pregnant, ideally she should not have been on it in the first place. We're really getting the word out there that it's so high risk in pregnancy, the idea is not to use it in any reproductive age woman. So luckily it's not that often, but you want to know about it if you do have one who's been taking it. I'm also going to mention some of the other anti-seizure meds because they have been tested in bipolar and they don't work. Topiramate, Topamax, does not work. Gabapentin, Neurontin, does not work for bipolar. Levetiracetam or Keppra does not work in bipolar. So the anti-seizure meds in bipolar are really a mixed bag. Call us at MCPAP for Mom or the psych treater, or if you're the psych treater, give us a call yourself. So listing the two that I think are most important to highlight in pregnancy. Lamotrigine, they've studied a lot of the anti-seizure meds in pregnancy because of the need to treat epilepsy in pregnancy. So lamotrigine, I have green. It doesn't look like teratogenicity overall is higher than the population rate. There have been studies, not all of them, but a few that say perhaps there's an increased risk of oral cleft defects. So that question mark is still out there, but the overall of the malformations possible, the risk is no higher than the population. Depakote, valproic acid, absolutely increases teratogenicity, up to 10%. Don't want to go there. Don't need to. One of the biggest concerns is the spina bifida, the incomplete closure of the spinal cord. So take that woman off. Don't, if you're a psych prescriber, don't start it in a reproductive age woman. For the newborn, the neurocognitive development is looking normal for lamotrigine. They have out for a year or two. So that's really reassuring. They're not looking, and it doesn't look like it's affecting the course of pregnancy particularly strongly either as far as weight gain or blood pressure or other blood sugar, other things that are often followed closely in pregnancy. But Depakote, we do have delayed neurocognitive development, IQ lower than expected. There should be no need to be on that. So this is a very data-filled slide. Green, if you remember, we have good data for the typical antipsychotics and lamotrigine. I think we could probably inch atypicals up towards there too. Caution with lithium, but sometimes that's really going to be the best choice. Again, with the yellow, give us, actually for all of these, the medications are just, can be complicated, give us a call. And I didn't mention carbamazepine. It's just very rarely used, but it also is an anti-seizure med to be avoided in reproductive age women. And then Depakote, stop those. Give us a call. Okay, so overall, ideally giving a psych prescriber a call, but not freaking out that the rules all changed. We continue these basic guiding prescribing principles. They're on our MCPAP for Moms website. Use what has worked. The only exception would be Depakote, or give us a call. Yeah, so don't use Depakote, but it may be lithium. Our main goal is to have the woman doing well, and if we know what's worked, we want to use that evidence for treating her. We want to use a low but effective dose. Unfortunately, it happens, but ideally, the woman's euthymic and on the medication, not having some continued symptoms. So we want to use an effective dose. Ideally, we minimize switching. It does happen in pregnancy, but we want to reduce the number of exposures and work with what the embryo or fetus has been exposed to. Again, ideally, monotherapy is preferable. The vast majority of our data is based on monotherapy, the risks I've mentioned. Adding anything with Depakote increases concerns of teratogenicity or poor outcome. We do know that. But the more medications, the less we know about interactions and fetal newborn concerns. Be aware of the need to adjust the dose. A prime example is lithium with the plasma volume changes over the pregnancy. And really discouraging stopping treatment right prior to pregnancy. Even with same with unipolar depression, that postpartum time is just such a high risk time. You don't want to take away for the woman. Okay, so this is so the key principles to take. It's been an honor to speak to you, and I wanted to leave a few minutes for questions. This is the MCPAP for Moms team. Dr. Byatt did introductions, and I'm going to put our phone number up here again, and our website is chock full of excellent information. So thank you. I appreciate being able to see you.
Thank you, Wendy, for that great, summary of bipolar disorder, which, as you nicely outlined, is it's just so important, and it's complicated, and it's, it was a great talk on it. And I don't see right now any questions in the chat box. Does anyone? I think people have the opportunity to put questions out, right, Beth? Does anyone have any questions? Or you can put them in the chat box, right? I think, Beth, are people muted or not? I don't know if people can say them out loud too. I'm not sure.
I can take a moment and talk about breastfeeding as we wait.
Oh, that would be great. Yeah, Wendy, that would be great. Thank you.
Yeah, the overall on that is our main goal, again, is to have the woman doing well, especially during this high-risk time. And if lithium is the medication that she's using, this is the one time that we do recommend not breastfeeding while on lithium. There's a high passage of lithium through the breast milk to the infant, and we know it does have risks for the newborn, the infant. So if lithium is what works for her, then definitely don't breastfeed. And then the other ones, it's more of a discussion. The passage through the breast milk is much lower. we don't see as many risks in the newborn given the exposure. And, you know, doing what works for the mother so she can keep a healthy, regular schedule, whether that's, you know, having someone else feed the child overnight, or she's on her own breastfeeding so she can just roll over and feed the infant. Those are things to consider. There is going to be exposure. It does pass through the breast milk, but again, it's pennies on the dollar compared to placental exposure. And we want that mom doing well. On the flip side, formulas have improved over time. Generations have been brought up on formula. If I could wave a magic wand and not have this woman guilty or stressed out about her decision, that's the most important thing for the majority of our psychotropic medications. So really the only one with a red X on breastfeeding is the lithium, and the others really need a full conversation so the woman knows the risks if she's going to try breastfeeding on the meds, or where formula may fit best into her overall picture.
Thanks, Wendy. That's a great, that's a helpful overview. Okay, well, does anyone, just looking at the chat box here, like having trouble seeing it right now. Let me see if it's showing up. It's like my computer's freezing. Nope, do I see any? No, I still don't see any chat box questions. Okay, well, we're just about at time. So thank you very much, Wendy, for the talk, and thank you all for participating. And we'll be having another one in about soon, and we'll send information about that. Thank you.